hope it works. Thank you very much for the invitation to talk about our options for the vitreous floaters. And I just want to ask who of you are doing cataract surgery? Everyone? Refractive surgery? And vitrectomies, retinal surgery? Okay. And I think for those with the vitrectomy, this is the way we want to see us. And I think for those who just do the cataract surgery, it's really good to cooperate with a retinal surgeon to just have them back up. And these are the indications we are used to do. We do the retinal detachments, macular pucker, vitreous hemorrhage, macular holes. And we are used to see this patient with reduced visual acuity. And our goal is just to bring them back to reading ability. And I remember the times when we just saw these patients with floaters and just say to them, it's not dangerous, you can go home, try to live with your new friends. And when they asked for surgery, this was our reactions, I think. There was no doubt to doing a surgery in those patients. And why we react this way? Well, it was hard to believe that the floaters cause that much reduction in visual acuity, and we were not taught in the university or in the hospital for treating this kind of patients. Several years ago, I found an article, I think it was an American journal, about the quality of life in patients with vitreous floaters, and it was very interesting. They just tried to find a tool for the evaluation of the kind of the level they suffered. And when they compare it with other things, and the patients with floaters are just for the symptoms like the patients with HIV or cancer or mild stroke. And this was very surprising for me. And there was another tool, like the Faustian deal. They tried to find out how would you trade to get rid of your floaters. And this was the answer. 25-year-old floater patient would give 7 years of their life just to get rid of the floaters. Another thing was like gambling. They just try to find out it also how you trade it, what kind of risk you would take to encounter just to get off the floaters. What do you think, Tobias? When you could die in a vitrectomy, how much % you get gambling? When you say it's 1% that you can die at a surgery, you would do it? Yes. It was a little bit more. It was 11% would take this risk for death or for going blind. So that means for us, visual acuity is not visual quality. And this is, I think, more than 10 years ago, we start to implant aspheric IOLs, and we just start to learn about contrast sensitivity. And it's just not the visual acuity, it's also the contrast, what goes down. It is very important for daily life, for driving, and it is no problem for us to take out the cataract and put on an IOL when the patient have a contrast sensitivity which declines. But when it comes to those patients with the floaters, we just say to them, learn to live with them and try to adapt to it. But adaptation, I don't really think that it really works. When the floaters just stay in the same position, there is no real adaptation. What is your
as I said, the anxiety is a problem, and most of the patients are very sensitive. You don't get the other ones. No.
So for me, it was, I think we start 5, 6 years ago doing the vitrectomy in this floater patient. It was surgery. And this is a nice paper from Siebeck. He just looked for the effects of the vitrectomy. And as you can see is that the contrast sensitivity, this was the first tool, the contrast sensitivity is worse in those patients with floaters. And after vitrectomy, it declines or it goes up to the normal level. So we have a real positive input of eradication of the floaters. And also for general vision, near vision on driving abilities goes up after vitrectomy. So it really makes sense to help those patients. So waiting, when we have no medical contraindication, observation, I think, is no longer a real option. So we have to do something. And I think the patient had a clear medical benefit from surgery. But why should one be careful with surgery? Patients asking for surgery despite full visual acuity may have difficult personalities and may be more likely to complain and cause problems after surgery. And we have to try to avoid complication, and we can really get hard complications with vitrectomies. One is developing cataract. Well, I think it's not the main problem when the patients are older than 50 years, but we have other complications which may occur. This is a patient from a colleague operated with laser-vitreolysis and with a partial vitreous detachment, and you see how he has to pull up the vitreous to get off the vitreous completely. And what happened is he had here a retinal detachment with a retinal or giant tear, so I have to do the laser coagulation. And it's not just easy to go in the eye, operate the floaters, and you go out. Something like this could also happen. In this case, it was also for a floater. This was surgery for invisible floaters. It's mostly in the bursa premacularis. So you see that after giving triamcinolone, that the vitreous is still attached, and you have really to rub it to have the possibility to lift up the vitreous. And this patient had visual acuity of 0.8. And I think, so the colleague have also done a ILM peeling in a 25-year-old patient just to get rid of these floaters. Next thing, what could happen, you have always measure. This was too far, too posterior when you get in the eye and you see that you perforate it and you have a retinal tear there. So even if you think vitrectomy is an easy thing for the floaters, something like this could happen. And if you are going too anterior, like this, you get a bleeding in the anterior chamber. So even when you think it's an easy job, complication can occur in those patients with this good visual acuity. Vitrectomy can really be dangerous. So what are the risks for the vitrectomy? It's preoperative. In 20% we have retinal tears. So we have to check the retina completely with contact glass. For intraoperative complications, if you do the induction of the PVD, you get 30% of a retinal tear. If the PVD is present, it's about 10%. After surgery, you will get 50% of cataract, of edema 5%, macular edema 3.6%, and the retinal detachment that occurs of the study could be between 0 and 11%. And even after some years, they could get a retinal detachment. There is a possibility to do a less invasive vitrectomy when you really do no induction of PVD. You just get into the eye, in the eye, go out with the floaters, and then you can drop down the possibility for the retinal detachment to 0%. And you have to check the retina and to treat all the retinal degenerations before the surgery. And when we are just performing a core vitrectomy, the cataract induction could be to up to 25%. So doing, I think, so 50 cases per year, we just were searching for a less invasive procedure, and Carl told me about the possibility with the laser, and he was very enthusiastic, and I said, doing the laser and the vitreous, I don't know if this is real, I don't know. What do you think about at the university of laser and the vitreous? Do you like the idea? Yeah? Okay. So this was our recommendation. When the patient comes with new floater, you have to look for retinal break. Retinal break or retinal degenerations, and we will find, if you do it really exactly, up to 15%. And I remember, I think, 3 weeks ago, I have a patient, I was in a hurry, and I looked not really good to the retina. 3-4 days, he come down to Carl, and Carl had a lot of time for his patient, and he searched, and at the end, he find a retinal tear. So if this occurred, you have to wait for 3 months, and if you look really with the optomap, it's really a good possibility to find the retinal breaks. And you have to ask these questions for the patients, and we wrote down this and the answer of the patient just to be sure that you really have problems, because when you have got complications, you always can show it to them. Okay, the patient have these problems with the floaters, and it was really demanding to do the surgery. For all the floaters, this was the question. It have to be 2 or 3 millimeters away from the lens or the retina. Then you are in the safe place to do the laser surgery. This is also, you're saying, we see a lot of funny pictures from the patients. And here just some examples of our patient. It really is nice and simple to perform, and the patients are really happy. This is also a patient with a bigger floater. Yes. Gone. And I have to say that I think nowadays 80% of our laser procedures is done by Roxana. So these are the measurements from her. This is also one patient with the floater, and you see the gas bubble, and you have to tell the patient that he will see the gas bubble, and they will go, or they see it going down. There are not new floaters for this. This was a nice case with a lot of laser, because he had retinal detachment and retinal tears, and the patient was myopic, and he was still phakic, and he has this big floater. So what you should do? For vitrectomy, I say, okay, when you do the vitrectomy, you will get the cataract, then you put a lens, and then you have to think about the second eye, and then you induce the PVD, and then you will get a retinal detachment in the second eye. So we just try with the laser, and it really works without a retinal complication. The retina was saved, and so this was really nice. This is something you asked Tobias, what happened if you shoot in the retina. It happened, the patient was moving his head, and it was just bleeding, and after 10 days it disappeared. And I think you could also think about just doing a laser when you're really are afraid. At this position, we do photocoagulation panretinal, and the patient has no problem with it. So this was the next case. You said this is not possible to treat patients with this. He had a floater, and this was the problem. And I also think, okay, we have to do the vitrectomy, but Roxana put the patient for a laser, and she hit it, and the patient was happy. So floater is not floater. We have to talk about the primary floaters and the secondary floaters. Secondary are more difficult to treat. In this case, I really performed the vitrectomy, and you see that the vitreous is it's not like a normal vitreous, it's more sticky, and that's the reason why it's not really possible to treat those patients with the laser. Then I learned from doing the studies with Jetrea or the oculoplasmine, the effect of the cataract surgery of the vitreous. You induce 21% of a PVD in the first week after cataract surgery, and in the first month it's up to 31%. And this is something I never told my patients before. But I think that's the reason when they come back and they say something changed after the cataract surgery, and this was not so much a problem. But nowadays with the premium lenses, and my colleague Dr. Breyer, he puts on the multifocal lenses, we have a little more patients now with these problems, because we know patients with multifocal lenses have a reduced contrast sensitivity, and they complain about PCO much earlier than the patient with monofocal lenses, and that's the same with floaters. When they have the clouds, they come earlier to us for treating, and I think that's a new option also with the multifocal lenses we have to treat nowadays. So with vitrectomy, yes, it's still, I'm doing it, but I could say that always you have to try the vitreolysis first, and that's my first choice for treating the floaters. Thank you very much.